Sarah? Give everybody another couple minutes to get signed on, see if we get close to a quorum. Gotta watch the other screen. Sorry, I didn't see Joan. Welcome. Andrew, Brenda's on. Lusa, nice to see you too. Joan, I thought you might be at the county's budget meeting.
Nope, I got out of that one.
Congratulations. Sorry, this is your consolation prize. Two, three, four. It says 5. We'll go another minute and I'll see if I can get a better view so I can see everyone. Asha, welcome. Okay, well, I think maybe we'll start to respect everybody's time. Apologize. Well, I don't apologize. We're on Teams today, which is a little different because the county folks are all in a budget meeting. So I don't know if we've done meetings by Teams before, but if you in the last 4 years you haven't ever used Teams, it's just a possibility, I suppose. There is a little hand at the top of your screen that says raise underneath of it if you want to have a question or need to get called on, and I don't notice. That's a way to flag that, and we'll see it. Also, the chat is available if you want to use that as well. And we are recording and transcribing, so we can use that for the minutes as well. We don't quite 1, 2, 3, 4, 5, 6. We don't quite have a quorum. Oh, there's Jason. Actually, so now we do have a quorum. So with that, I'll call the meeting of the advisory panel to order. You've got minutes from the January 17th meeting. One thing I do know we need to correct on that, Latasha, we had you listed as still as president and CEO of Humankind. We need to update that with your current title, and we'll make that change. Are there any other changes, additions, deletions, updates to the minutes that anybody has? Don't see any. Entertain a motion to approve the minutes as with the proposed change for Latasha's title.
So moved.
I'll second.
Heard a motion. Jason seconded. All those in favor say aye.
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 Any opposed? Hearing none, minutes are approved. Thanks for that. So today we're mostly going to do updates on the project. A couple from our team. We don't have the county folks, so we'll try to, well, we do have Andrew, so if you have a question about the county, or Andrew, if you want to chime in on construction, you're more than welcome to do that. The main agenda item is an update from the KDAD's behavioral health team on children's services. That came out of a recommendation that you all made just to get an update on youth services. Our hospital is primarily focused on adults, but that's certainly something that came up in the law enforcement sub-panel a couple of other times as well. So Taylor Bremer's on from our behavioral health team to do that update as well. So with that, let's go into the construction update. I think we introduced Adam or maybe we announced Adam last time we had a panel meeting, but Adam Crocker is on. He's our facilities director for the South Central Hospital. Lives in Wichita, has an extensive experience in construction. We're lucky to have, he's been a great addition to the team on a couple of fronts. One is that he lives in Wichita, and so he can be there on site, but he's also bringing a lot of construction experience as well. So I asked Adam to do a brief update on the construction part of the project. So Adam, if you would go ahead, that'd be fine.
Thanks, Scott. Afternoon, everybody. Yeah, the work's being completed in the areas of grading within the building pad area, as well as starting to grade and cut the parking lots and the loading dock areas. Priority focus has been on the ground level grades and stabilization for the ground so they can start building the foundation pad for the building itself. Continue daily monitoring on that ground level settlement plates to ensure the proper levels are settling before the work continues. They are making progress on that, which is really good news. Waiting for approvals from the Kansas State Fire Marshals, as well as Kansas Department of Health and Environment. Utility service providers have been identified. Electric is Evergy Energy. Gas is Kansas Gas Service. Internet, Cox Communication. Water, City of Wichita. And sewer is City of Wichita. They're working on bringing commissioning agents on board through the FRP within the county. And the bids to be read right now focused on February 25th with vendor for materials testing on the existing contract. Sorry if I went a little fast on that, but that's a brief summary of what's going on. And I can email that to anybody who needs it too.
That'd be great for the minutes. You can just email that to Arena and I and Melinda and get it in the minutes that way.
Sure.
And I was trying to count names again. So what date does the commissioning vendor RFP open? That
Right now being read on, yeah, right now on the 25th of February.
Andrew, since you are able to be on, anything you want to update from the county's perspective?
No, I think Adam pretty much covered it. We are monitoring the settling plates. We should have another measurement today, and hopefully we'll have be able to proceed forward with the vertical structure in the very near future.
Okay, any other? So the site, our part of the site is clear. There is a crushed rock pad with a building trailer on it, and there's a lot of equipment moving. If you remember the site plan, there's a water retention area to the north of our site. They're working a lot on getting that to the right level. So yeah, a lot of industry that's happened in the last, just been a month, but a lot that's gone on there. Any other questions on the construction part of the project? Don't see any. Okay, we'll do a couple of other just project updates. Arena, you want to go first, and then I'll do my short legislative update.
Sure. Good afternoon, everybody. So at the last meeting, we solicited interest for the Citizens Advisory Board here with this panel, and then Greenbush helped us reach out to the subpanels, law enforcement and workforce development subpanels, also with an invitation to join Citizen Advisory Board or for candidates. We had some interest, and 7 people expressed interest for the Citizens Advisory Board with a good mix from law enforcement, consumer advocacy organizations, mental health centers, and medical community, and also expertise in workforce development and nonprofit management. We developed a formal application and approval process and said that the first round of members will be approved by the steering committee or its subgroups, and we had 1 full application so far and had 1 approval. So we have 1 approved member for the Citizens Advisory Board. For the 501 3C organization, we had C3. We had only one interest, and honestly, a lot of very good questions that came from Latasha, and the questions that we really need to answer to be able to successfully move forward. And with that, we did some research as to how things are set up currently at the other hospitals. So some of the questions are if we can or cannot use dollars that we currently have for the project to get the foundation set up. If we are planning or not planning to hire the executive director or CEO for the 501c3 or this foundation to manage the actual activities of the foundation, or would it be managed without hiring the formal director who will be paid for the job? And if we're going to have a board that is more sort of advisory, or if it's going to be operational, definitely understanding that it's easier to bring in people who will advise rather than manage the day-to-day operations of the foundation. So we went to see how it's currently set up at the other state hospitals, and all of the foundations were set up with assistance of pro bono lawyers, and one is actually in the process of getting set up. None of them have a paid CEO or executive director, and all the operations are carried by either the board or the members of the organization. So basically, none of them have paid employees, and that's how they're set up. So if there are thoughts on how the panel would like, if you have suggestions on how we should set up or thoughts on how we should proceed with that, I would love to hear your thoughts on that. Yeah,
Latasha, go ahead.
Yeah, thanks. So yes, we've exchanged a couple emails just because I had some very specific sort of business behind the scenes kind of structural questions regarding the 501c3. And so I just wanted to clarify in some of those other examples that I know the team has been looking into, and I'm happy to make some phone calls to some colleagues as well. But so in those examples, the staff carrying out the work are actually staff members of the hospital. But I'm assuming, which is always a bad thing to do, but in this case, I'm going to go ahead and do it. I'm assuming, though, that those roles are very specific and they actually have a function that's associated with the foundation. If you look at some of the children's hospitals around the country, even if they have a foundation arm, there might be a staff member that is responsible for, let's say, donor relations or the management of those funds, but they're actually paid staff by the hospital and oftentimes office in that hospital and so on and so forth. So I guess from an operational perspective on the hospital side of things, have those positions been identified and agreed upon in the ongoing operational budget of the hospital?
So at this point, we have not planned to have positions that would specifically be dedicated to manage the operations of the foundation.
I would say, sorry. That's not my grandson. That's my granddaughter. So I guess at the other hospitals, like the CFO runs the financial parts of the operation. If there's something that's being purchased or bought, then the purchasing department or the people who process vouchers, they just apply into the foundation funds. Then there are some other community folks who are involved in the decisions, but it's a job role related to the other job role that people have, either finance or accounting or payables, human resources to some degree, but so it's related but not directly tied to not separate and the loan just for the foundation activities.
Correct. And I guess my thought though is the hardest part of that equation though is going to be actual philanthropy, fundraising, and donor stewardship management, database systems that run all those gifts. So for example, if you look at, well, St. Jude Children's Hospital is probably a bad example because that's a huge and completely different sliding fees, scale kind of situation. But in general, I'm just long-term curious, unless your guys are hoping for organic funding to come into the foundation, which would be more probably what this is leaning towards than an actual setup itself to generate funding. Is that right, Scott?
I mean, on the other campuses, at least, so using that as the model, it's if we have a patient that's been a long-term patient, there may be some money that's left over when they pass or when they are discharged, and they donate that money back to the foundation, or a family that we provided care to over time at Parsons or KNI, and they make a gift to the hospital, or sometimes it is a corporate or business donation to support a particular project. So I don't fundraising is it. I mean, there are some fundraising activities, selling T-shirts, selling pens and flashlights, things like that, but not doing like a gifted, like a fundraiser, maybe a fundraiser, but not something that's going out and getting planned gifts or something of that scale.
Yeah, and probably not the intent to offset some expenses of the hospital in some fashion then as well.
That's correct. It'd be stuff to supplement. A lot of times that's where we get, if we're have money for patient benefit, Christmas presents, holiday gifts, holiday parties. Even at Parsons, a lot of our staff recognition is done through the foundation, that people are donating money then to support the staff who care for folks that we serve. So yeah, it's more patient benefit or staff benefit, not offsetting other costs of the hospital. Capital, we're not building things generally with money that we raise. It's going to maybe more indirect kinds of things, but still related to the care of patients.
Okay. And so there's no intent either then in the future, let's say distant future, that there would be a function that philanthropic gifts could offset the cost of care, because obviously those that are not insured, underinsured, or perhaps, just in general to take more patients on, or if there's growth, I'm wondering if that's ever been thought about or considered.
We don't have a model for that, but that doesn't mean we can't. It's something to certainly think about. It's just different than what we do now, but that's okay. This is it's a relatively fresh start, informed by what we do, but we don't have to be trapped by what we've done in the past. That's my opinion.
Well, today might not be the appropriate time to get into the weeds on some of this, but I mean, I do have some contacts across the country where there's different models for this, and they have different philosophies or what have you. So I don't know if there's a small subgroup that maybe would want to discuss this further, because there's a lot of details to probably iron out on the 501c3 side of things. And this is my personal opinion, and I know others might differ, and even in the nonprofit sector, everyone has a different opinion, but I would be reluctant to have a 501c3 and foundation and not have a single staff person. So I would be interested in, of course, like you got to do the filing, you've got to get your bylaws, your mission, like what is the intent behind all of that. But it's hard to recruit board members if you don't have a clear structural understanding, because their level of commitment, there's operational boards, there's strategic boards, there's social boards. I mean, there's all kinds of different board of directors or board of trustees. And until that's identified, I think it's going to be tough to recruit. And I also think it's going to be a conversation that if the hospital were to make an investment, or if you had private philanthropy willing to make an investment in the startup of this, but it is going to take some capital. So I think there's a lot more conversation to be had. as the nonprofit side of, or the foundation side of things continue to be discussed. And it's likely, the team is going to need help to walk through that and work out the details. And sometimes I think it's best to think about 10 years from now when you're doing the initial startup versus like, well, let's just get the filing done and, let's just get that, because you don't want to do all this work and then you get 6 months down the road and you're like, well, I wish we would have actually just planned for the thing we really wanted versus trying to kind of Band-Aid it. But that's just my opinion. And I don't know, today's call is an appropriate place to get into the weeds.
It's a really good thought, and I'm glad you raised it. The other part of it is this is a state agency, so we're not a university that has a fundraising arm that clearly has they identify their purpose, but we have taxpayer funding, Medicaid funding, other kinds of insurance funding. I don't know whether it's even appropriate. Some people might consider it to be inappropriate for a publicly run state-operated hospital to go seek private donations for pretty much anything. But those are good questions to ask, and exactly the right ones. And I appreciate we've got plenty on our plate to do. So, one more thing we ought to do it right for sure. But I think that's a really, really good thought. And certainly we don't ask people to sign on to a board or a board of directors without a clear idea of what their purpose is going to be. Any other thoughts about that, or others with thoughts or comments?
I appreciate Latasha's thoughts about it, and agree completely that we do need to have a clear idea, but also I agree that we have an opportunity to see what is the most effective model that we can implement here, and hopefully create a model that might be afterwards copied for other hospitals if it is successful and goes a little bit beyond what we currently have. But from the workforce perspective, I think it's important to remember that if we don't have dedicated staff, they will not really be able to make the full impact, right, for the foundation. And some of the things that I know other hospitals are struggling with is for discharge planning, and not necessarily maybe covering the services of the hospital, but helping patients with the afterwards journey, right, and making their life successful with resources that might be provided by this foundation.
Great. Irene, any other updates for the panel today?
No, I was only hoping to cover these organizations for today. Thank you.
Okay. Any other questions for Irina before I do my brief update? The update, one item I put on the agenda, one I didn't, just a quick legislative update. So we did introduce our bill that creates the hospital, names it, creates the catchment area, and also sets it up so that we can admit patients for care and treatment cases and for forensic cases. It's House Bill 2365. We had a hearing. Was that just earlier this week or late? I think it was earlier this week. It's been an eventful week. And it's been through the House action, and it passed 121 to 3, I think. So it's out of the House and onto the Senate for review with a couple of amendments to the original bill language just to clarify the counties that are in the catchment areas. We didn't have that exactly right, but so that's well on its way. Not hearing any objections on the Senate side yet, but we'll see what happens over the course of the next couple of weeks. And then the other was we are working on a groundbreaking. We've already started construction, so it'll be a little of a hybrid. Anyway, we had to take advantage of the time that we had, but we do want to recognize that we're starting the project and acknowledge all those who have participated, getting the governor involved, the county commission, legislators. So to get things out of the legislative session, we had to look into April. And so the date that we're tentatively looking at that the governor's office is reviewing is April the 9th, kind of midday, noon-ish, noon hour, maybe, but April 9th. It's a little bit out. It's a few days after our charge expires, but we certainly want all of you and the panel members to be involved. So we'll get an invitation to you once we get that finalized. But you might, if you're at a place where you want to pencil something in your calendar for around midday on the 9th, it looks like that seems to be okay for most of the parties involved. Any questions for me? Okay. Okay, we'll go to our, oh, I'm sorry.
Hi, Scott. Yeah, thank you for all the information. I think it was with the previous discussion. Are the state hospitals, do they have foundations and do fundraising?
Your sound is a little, well, now it's online too. Just a second.
Yeah.
Is that any better? You're a little helium sounding. Okay. I think I heard the question. Am I still sounding? Do I still have the helium sound? No? Okay. If the question was about other hospitals and foundations, so we do have an arena. You've done the background, so and I kind of know, but Osawatomie, there's a group called the Friends of the Mentally Ill. That's a patient supporting foundation. That's a board of directors of a lot of former staff and family members. Parsons State Hospital has a foundation that does raises money and does a lot of work around supporting the employees. K&I is in the process of forming a 501c3 nonprofit to do a similar kind of patient support and staff support function. And Larned, I'm not sure what you found out about Larned, but I don't know they have a separate foundation. But Irina, what did you find out about Larned?
Well, I didn't really find out much because that's they don't have much of a structure that's set up or not a very active foundation. And with Parsons, they have more of advisory role. The board of directors have more of an advisory role, mostly with bankers and investors, from what I understand. And OSH has mainly current or retired employees that, and some outside folks as well. And then K&I is setting theirs up, and their board members will manage the operations, and then the superintendent will be part of the board in advisory role as well.
Great. Okay. Well, we'll go into our presentation. Taylor, you can introduce yourself. I didn't introduce Brenda Soto. She's a good colleague of ours at KDADS, works at the Department of Children and Families on a lot of Medicaid issues with a lot of overlapping kids in the foster care system that are also in the behavioral health system and others. So Brenda's on as well. May say something, she may not. She's not shy, so she'll contribute at the appropriate time, or if there's a question that's more relevant for her. But with that, I'll turn it over to you, Taylor, to go through your presentation.
Okay, thank you. Yes, Brenda will chime in throughout if I'm ever veering off course or I say something wrong, because that is the type of relationship we have. I fully welcome corrections. So I'm going to go ahead and share my screen. And our team has put together this presentation for you all. And really, this is just a high level overview of some of KDAD's services that we support, and different types of services that are throughout Kansas for our youth. And there There we go. So you'll just see a high level overview. This is what I'm going to talk about. Again, I have about 15 minutes. So I think Scott is probably going to keep me to that. If I go over, Scott, please feel free to interrupt me, okay? So our McKinsey report, we had a external partner come into Kansas and look at our PRTFs. And so McKinsey's group in 2024 conducted an environmental study of the state's PRTF system, which really caters, our PRTF system really caters to our youth under 18 with severe emotional disturbances. So this report was funded by Medicaid. I'm sorry, the PRTFs are funded by Medicaid. And they really have a high overview of what we're looking at. So some of the complaints that I'm sure like the sheriff's department faces, I know ComCare faces really is we have this wait list that is attached to our PRTFs. And on average, there's about 130 kids on that wait list. And since about 2019 is when we started really focusing on how many individuals that we have. So what we'll see is that there was a significant increase in denial rates for youth with complex or specialized needs. So you'll see that on this chart. Don't look too closely into it because I'm going to go real fast, but you guys do get this slide, okay? So common reasons for denial really included the dual diagnosis, aggressions, and some cases we have kids that were deemed or labeled unplaceable. So the overall capacity of a PRTF system has increased by about 39% in licensed bed, but only about 19 in staff beds. So you'll see that's probably one of the reasons why we have this, right? Again, we've had an increase in those beds, but only about 19% of them we can staff with individuals. So some barriers to access include the lack of upstream prevention services, insufficient integration across the behavioral health continuum. So we can't get them discharged because we don't have a very good system set up. And then inadequate community support services. So really there are limited IOPs, so that's intensive outpatient programs and respite services, and discharge planning often lacks involvement from relevant stakeholders. So again, just some high level information for you all.
Taylor, can you maybe spend a minute describing what a dual diagnosis is?
Yes. So dual diagnosis is you're not looking at, well, they have anxiety and depression, right? Dual diagnosis is typically when we have substance use in there as well. And so when you have a kid who has anxiety, but then they come in and they also have maybe like heroin use or something like that, maybe not that extreme, but that's a good example for you all to see, right? Those come with some medical concerns as well. If we're going to put somebody in a PRTF that has extreme substance use, they're going to have to go through some type of detox. And sometimes that detox can become very dangerous. And so we have to make sure that our PRTFs are set up to be able to handle that. And sometimes it just is not. Does that answer that, Scott? Perfect. Okay. So again, this is just a deeper dive into some of those root cause analysis of why we're seeing this increase in our wait list, or not really a decrease in it. I will say though, we just presented at Bethel, and part of our written testimony did show that we have a wait list right now of 65 kiddos. Again, this is a place and time. It can change, but on average it's about 130, and that it kind of fluctuates based off of the seasons. Kids tend to be in PRTFs more frequently, and Joan can correct me if I'm wrong, like in the summertime, and then right about the time that school starts. So again, these shifts we can see those increases in PRTF visits. So McKinsey did offer some proposed solutions. So really this document outlines those recommendations for improving the specialized needs care and facilities, focusing on several key areas. So specialized needs. we really need to increase and convert maybe some non-specialized beds to specialized beds to meet those demands. Again, that could be being able to support our dual diagnosis individuals, but also our IDD individuals as well. And another thing that you will see is that we do get people that are on the wait list that might have some medical issues that are causing them to be higher level of acuity. And what that means is they don't have the staff and or the services to be able to meet those medical needs, okay? So when we say those types of situations, that's what we're talking about for specialized needs. Staffing would be the other thing. Implement a rates that supplements to incentivize the development of those specialized beds. We could adjust their per diem rebasing, and then also the care continuum, right? So we could have some type of mandate, or we could really encourage these post-discharge programs to support youth that transition back into the community. Right now we have Ember Hope, who is doing some of that. And so we're seeing some good stuff coming from there. Okay. Just want to make sure I'm not going too fast for anybody. Is this okay? Thank you, Scott, for putting what a psychiatric residential treatment facility
With the exception
is.
of acronyms and maybe some terms that people aren't going to get right away, but I think you're doing fine.
Perfect. Thank you. I will try to not do my acronyms. Okay. So like I mentioned, again, this was a slide that I developed, or I had staff develop back in January. So it was 75, right? So we see that it is decreasing. It just, again, it's a moment in time and it can change. We do have all three MCOs trying to make good progress on connecting members to community services. So they're working with the certified community behavioral health clinics. So those are the CCBHCs, and what they were called before they became CCBHCs were the community mental health centers, and that's CMHCs. So if they can have lower level of services, they will connect those individuals there. And while they're on the wait list, typically that is they're getting services through that lower level of care, but it doesn't always meet their needs. So some other organizations that we have going on that really help provide youth voice and champion the youth are all of these organizations, right? Y-Link is underneath our Children's Behavioral Health Services here, and Gary Hinault oversees that. Then I know Brenda was like, can you put this one in here? And so that's the Kansas Youth Advisory Council. And so those are for foster kids, and she could talk more about that after this, unless she wants to interrupt me now, she totally can. But so these are just high level, again, different types of services that are available. And I really do encourage, if you don't see these in your community, to get in contact with us. We can definitely hook you up to any of that, but we are seeing good results, especially with that Y-Link. I know that Gary is constantly talking about the benefits of having Y-Link in communities to give youth voices. So MHIT. MHIT was actually moved to KDADS from Kansas Department of Education back in 2024. So this fiscal, state fiscal year. And really what it does is we're able to provide school-based, we fund school-based liaisons, right? And those will be called SBLs. I think there might be some acronyms on this. And they identify students needing behavioral health services and connect them to licensed professionals who then provide intense individual therapeutic services in school setting. Right now, Kansas has not expanded our ability to provide services for kids who are on Medicaid outside of an IEP. So MHIT comes in and is able to provide services to individuals through this funding that are needed for that. Right now, each of the MHITs, there's over 100 schools, and they're able to customize their programs that fit the needs of their individual students, the families, and the community. So engaging in MHIT is voluntary for these USDs. And I know that last year was a proviso that we were supposed to include qualified schools. So about 1.5 in startup funding to include qualified schools. So we do have some private schools that are included in this as well. 988. Right now, I'm not going to spend too long on this because I'm running out of time, but 988, our answer rates are about 89 to 90% on average since 2023. Some nice little tidbit that I got from Laura was nationally, they have found that 988 is only known to about 1 in every 5 individuals. So the marketing is still needed there to be able to utilize 988 as it were like 911, right? So 911 physical, 988 behavioral, and we're not there yet, but I know that Kansas is working to get us there and to get that integrated. I believe for 988, there are a few community mental health centers that are working with their local sheriff's departments or police force to be able to say, like, if we get a 911 call and it seems more behavioral health, we then contact the community mental health center, and then they're able to work with that individual at that time. And so I've heard really good things about that. The centers are doing awesome when it comes to being able to field those calls. So the mobile crisis response and the mobile response and stabilization services, again, this is kind of that just go model. They get a call and the provider, which is our community mental health centers or our certified community behavioral health clinics, they receive the call and they say, hey, this individual is needing care, please respond to them. The goal is to have a response less than 2 hours. It requires a physical response at the place of the individual in crisis's choice, 24/7, 365. Okay, we're still building up to that, but I know that we're doing some hard work. Again, this goes with that model of 988. Then we also have the relationship with the sheriff's department and the police force and saying, hey, we have this individual, there's no need for us to get involved. It's more mental health, behavioral health. Can you all take this on? And so those partnerships are growing.
Hey, Taylor, is there any difference between 988 response or mobile crisis response for adults and kids?
Absolutely. Well, here's the thing. No, it is a just go model for both of them, right? The difference is, and I believe Brenda might speak to this a little bit more, right? We have here in Kansas, we have an agreement with Carelon and with the Association of Mental Health. And what we would like, right, is Carelon filters out for, or they're the response. So they get it, they triage it, and they say, okay, we have this. And if it is for anybody under the age of 21, correct me if I'm wrong, Brenda, they are to respond to it and then provide that information back to Carelon. Do you want to add anything else to that real quick? No? Did that answer your question? Woo! Did that answer your question, Scott?
It did, yes.
Okay, perfect. So this also kind of just talks about that briefly, right? This is the Family Crisis Response Hotline. So in January of 2021, DCF and Carelon partnered with the Association of Community Mental Health Centers to develop the Kansas Family Crisis Response Helpline. It was launched in October of 2021, and the intention of the program is multifaceted, including assisting Kansas youth ages 20 and younger who are experiencing crisis situations while avoiding the need to engage law enforcement or making a trip to the emergency room. So this, again, this crisis line very similar to what I was just talking about, if not exactly correct. The crisis line is staffed by the crisis professionals, and it is available 24/7. Okay. It is free. The service is free of charge, with or without Medicaid, and the program applies to all Kansas youth, not just foster children. So again, when I'm talking about Carillon, we'll dispatch our community mental health centers with that Just Go model. This is part of that. It does not matter if they have insurance, if it's Medicaid, if they have no insurance, it is free for them to utilize. Juvenile Justice Stepping Up Initiative. So KDADS is working on this early intervention system for vulnerable youth and their families, and we're working in partnership with KDOC, Kansas Department of Corrections, DCF, OJA, KSDE, and KDHE. I'm not sure the acronym of OJA. Can anybody help me out on the top of my head? Thank you, Scott. Okay. The goals of this are early intervention systems, and they're to advance the public safety, improve health, youth outcomes, and reduce unnecessary involvement of juvenile justice and child welfare systems. So really, we're working on implementing all of these things to keep kids out of the system, okay? Whether that's in DCF or in the juvenile justice system, we are working to have these preventative measures put together. So additionally, KDOC is leading the planning process in the collaboration, right? So they're providing representatives and other stakeholders to strengthen this approach and use and the appropriate use of like the detention centers that we have, and to improve the use of research-based assessments, services, behavior management strategies, detention alternatives, and re-entry practices in the detention facilities. So the goals of this plan are really to ensure the detention is used statewide only for youth who are public safety / flight risk. So youth who are placed in detention receive the services and supports they need to reduce their risk of reoffending, and that the detention facilities across the state adopt a minimum set of practice standards and receive that sufficient training and support while they maintain local autonomy and discretion. So our KDADS is currently in contracts with KVC Hospital that provide the youth an inpatient CECR, which is that competency evaluation and restoration. So in 2024, the services were provided to 11 youth, and to date, as of 2025, we have 6 youth that have been served. KDAD's contracts with Wheat State Healthcare to provide that mobile youth outpatient CECR service. And they are partnered with Learned State Hospital to develop the training specific to the unique needs of youth ordered to the CECR services. These are some of our respite beds, crisis services. Again, we want to make sure that kids are getting the treatment that they need in the community, because Olmsted tells us this is the best course of keeping kids in their community, has the best outcomes for adults to keep them in their community. So we provide, well, we don't provide, community partners provide crisis and respite services. So this is just a high level overview of the centers that are doing it. Again, we are working to build that capacity with crisis intervention centers and then crisis stabilization units. So I believe you can click on these and it can take you to their website. So when you get these PowerPoints, feel free to dive into those. So this is really where we want to go, right? We want to continue to add capacity for the specialized and non-specialized beds in PRTFs. We want to continue to broaden our behavioral health continuum. So we want to get upstream as much as possible. This is our end goal, is to keep kids in the community. Again, we are hoping that by doing that, we can avoid having adults that are in and out of state hospitals, in and out of EDs. The earlier prevention, the better. Also, we're working on getting a youth governor's behavioral health service planning council committee And so again, with that idea of developing that upstream prevention-based framework. And I think that's it. Okay. So these are my directors who put this slide together. I could not have spoke to all of that without my subject matter experts. So what questions do you have for Brenda and I? Let me move my screen over here.
Latasha, your hand's up. If you've got a question, or it might have been up from before and I just hadn't paid attention. Okay. I think I can lower it. Any questions for Taylor or Brenda? Usa.
Yeah, thank you, Scott. Yeah, thank you, Taylor. Great presentation. A ton of information. I guess my question would be, and you may have mentioned it, do we have any kind of data or trending points about how effective these programs are being in meeting what they're supposed to be meeting and their goals?
I'm going to do my best. I'm going to do my best to, oh, I'm also a chipmunk right now. Did that work? Nope.
Usa, if you mute, then I think Taylor's response won't be garbled. I think that'll, okay.
Did that work? Okay. I'm so sorry. So I believe the question was, do we have any data that shows the how effective these services are? Is that correct? Okay, so we are starting to gather that data with our data warehouse. With becoming CCBHCs, we do have that agreement and we're able to start seeing where we can make the changes, how effective like the just go model is going. And then for PRTFs, if we, for like Ember Hope, right, we're going to see how long do they stay out of PRTFs or long-term care or EDs and stuff like that. And then we're able to start measuring that, how effective these types of interventions are. So I would say that we're in the very beginning of collecting that data and then being able to analyze it. Unfortunately, as I'm sure we all know, data takes time to tell a story. We can look at data at the early stages of anything and be able to say, well, it's working or it's not working, and then make changes. But we want to be very strategic about what we're looking at and how that, if we were to make changes too early on, before we could see the actual outcome, what that would do in the long run. Did that answer your question?
Yeah, it did. I guess the reason I ask is there seems to be, I know some of the stuff that's happening in Riley County and in Manhattan as far as mental health services. So just to make sure, there are so many programs out there. And so if you only have like 8 students or 8 youth using one and 15 using the other or 100 using one, if we can put more of our financial resources to have the most impact on 1 or 2 as opposed to 10 different ones, that way you would have your workforce also very focused on same job titles, but very focused in a few initiatives as opposed to so many initiatives. And that's just a thought that I have. It's not something you have to answer or anything, but it's just the way my head works, and I see so many things. Sometimes somebody who's in who needs services is very overwhelming, and could be redundant in some cases.
So I think I'm going to summarize for us, because I could be not hearing that correctly, but I think it was more of a concern if we spread out too thin, then are we putting our money to things that are truly impacting, or are we diversifying too much? That way we can't see the actual impact, and maybe we need to condense, I don't know, services and put money towards that. Is that what I'm hearing? In a roundabout way?
That's the question too. Yeah.
Okay. You know, I don't have an answer to that.
there are, I mean, this is not one of the areas that I'm responsible for, but in knowing some of the history of it, some of it is there are lots of paths that are similar, and then the local areas can decide between the mental health center and the courts and others that are involved, maybe where there's an inpatient provider, which of those models works the best. There are some things that we do know about mobile crisis, and 988 is a single number to call. Those things make sense everywhere. But then some of the more specialized services, again, just because of the scale, maybe you're talking about 3 kids a year or 100 kids a year, you just have to do things a little differently. But I think the models that we're promoting, it's a good point, because it does seem like a lot of different ways of getting to the same issue, but it does give some flexibility for local conditions. That is probably why we have this topic on the agenda, because we wanted to make sure we understood what the state landscape was and how it fits with not so much what we're doing in Wichita, but other things that are going on in the Wichita area. But it's a really good question, because it does seem like there's a lot of different things going on to address generally the same group of kids, but it's not always the same group of kids, and there's not always the same set of solutions to the problem, depending on the local jurisdiction.
I think it's also important to note, right, that when we don't have as many opportunities for access to care, right, we get what we identify as a bottleneck, right? And so I think what you see right now is us trying to figure out how we can make sure we are capturing as many people as possible and making it less difficult to get access to care. Again, it's that upstream approach, right? And it takes, unfortunately, us learning and growing to figure out, and again, with that data piece, figure out what is working and how we can improve it. And Brenda just came off mute, so feel free, Brenda, to interrupt or add to.
I was going to mention, Taylor, is our policy academy that we went to. It was a national policy academy, really looking at the state level and looking at what each of your sister agencies, what we're implementing, what we're doing, but also taking it down to a service level of what services are available in your state. And so one of the things we brought back as the Kansas team was creating a children's continuum of service and treatment across the state. It's pretty broad. So the way it was organized is to look at from a state perspective, what are all the state agencies, doing a glossary at the beginning, but then looking at the least restrictive services and or treatments that are available all the way to the most restrictive, which would be hospitalization. And so we have that document. Taylor, I can get you the most recent. I just updated it here recently. I'm lucky to be selected as the author, because I had started the work before we went to the Policy Academy, because I really feel like in the state, we have a good pulse on some of the things that we need. But I was like, do we really know across the state what services are needed from our communities? And I was also looking at rural, right? We have a lot of rural communities that don't have access to treatment or services, and they have to drive quite a way. So I was like, we need something to gauge that. And the hope is to take that document at some point and put it be more of a dashboard and be down to a county level. So I can share the latest with Taylor so that it can go out. But I also think that should be done on the adult level. So hopefully at some point, someone on the adult side could do something very similar.
Great comment. Other questions for Taylor or Brenda? I will say this was a recommendation of the panel to get a briefing like this, so you can kind of noodle on that. And if there's something else that you'd like to hear about, we can go back and fill in the gap in the month that we have. I will say, I understand that not everybody retains everything that they hear, but as we're talking about the bill and our hospital getting started, the 2 questions I get most consistently are there going to be beds for kids? And will this facility be able to serve kids that either are involved with the justice system or are have really high behavioral needs. They have intellectual disability and a mental illness and so it makes it, they're coming from a different system than ours. And I get those questions from providers. I get those from families. I get them from legislative elected people. I get them from Brenda. I get them, I mean, lots of people. So again, I think we've been pretty clear about the purpose, but that doesn't mean we've met all the needs either, which is on the days when I get a little, when I feel, like we've made a lot of progress, there's still some unmet needs that we need to, I don't know, it's our purpose to think about, but we need to be aware of it as part of the community that we're moving into.
Yeah. And that just to speak to that, I'm so sorry, Scott, is really those specialized beds, right? That is where we're seeing a lot of that need. And so when you think about specialized beds, think about your IDD population, your aggressive kids, your kids with that dual diagnosis of substance use disorder. And so those are the populations that, and I know that this came from maybe the sheriff, like the request for this came from the sheriff's department. Those are the kids that typically they're going to see the most, right? And they're the ones that are waiting in our EDs. They're the ones that the community mental health centers have been working tirelessly with, or the CDDOs have been working tirelessly with, and they've just run out of community-based supports to be able to get them regulated again. And so when we're talking about those specialized beds, that's what we're talking about.
That's a great point. Other questions? Okay. Well, thanks, Taylor and Brenda, for your contributions. I like checking things off the list as we're getting down to our last month, and this is one of the items that we can check off the list. Important information as well, but we're fulfilling that recommendation. That's our agenda for today. We will meet again in March, and that will be our last scheduled meeting, with maybe the exception of the groundbreaking. If there are, we're going to go through the recommendations again and make sure if there are any other items that were recommended that we can cover in that last meeting. Certainly give you an update on construction and where we are. But that'd be our purpose in March, and hopefully we have some other legislative updates to provide by then as well. We should. I think we'll plan to meet in person since we haven't done that in a while, which I appreciate everybody's flexibility to do that. But we'll try to meet in person in March and wrap up our work, except for the groundbreaking, of course. Any other questions or comments or things from panel members?
Sorry, Scott, will you send out a calendar invite for the groundbreaking or more detail? I mean, are you going to be sending out calendar invites in general? I know you do a great job, but I just thought I'd ask. I
don't do a great job, but that's kind of you to say it. We will. We'll do a written invitation, because we are working on an invitation list and attendees and things like that. We may actually ask all of you, if there are other people we need to be sure we invite. We'll give you the broad categories, but we want to make sure we're inclusive and make it kind of a big deal. But I think the last message I had from the governor's office was yesterday, confirming the date, and we gave them the time, which is a little different than they originally proposed. So I'm just waiting to hear back on that. And then I think we'll be, maybe next week we'll have it locked down to a date and time for sure. And I have a lot of accountability partners on the call too. So it's not just me that has to remember, it's a lot of other people are helping back me up. Okay, any other items for today? All right, I thank y'all for your time. I entertain a motion to adjourn.
So moved. Oh, got it.
Mary, I heard Mary move, and Latasha seconded. Any objection to adjourning? Hearing none, I will stand adjourned for the day. Thanks everyone for being available, and we're shifting things around, but one more meeting will be wrapped up.
Thanks.
All right, thanks for your time.